My name is Dr. Yuliya Linhares, and I'm Chief of Lymphoma Services at Miami Cancer Institute, Baptist Health, South Florida. Our practice is located in Miami, specifically Kendall area, and we serve large population in the South Florida. Miami Cancer Institute is affiliated with Baptist Health, and it's one of the largest cancer care providers in Florida. So CTCL is a very rare disease. So on average, there are about 6 cases per million per year. So the challenge is really the rarity. And of course, pathologists are trained in diagnosing this disease, but still it's best to have pathologists who are specifically trained in hematopathology and more so specifically trained in cutaneous T-cell lymphoma, just because there can be so many lookalikes in benign skin disorders, and the diagnosis is not always clear. There's also something called pre-mycotic stage. So basically, the patient may be in the beginning, in the early stages of mycosis, and it's not clear whether it is mycosis or not. There are also several components of the assessment that need to be done. The biopsy has to be done correctly. We have to look at some molecular studies. And also, we need to correctly stage this disease. So to correctly stage this disease, we have to remember this is not just a skin disease, even though it's called cutaneous lymphoma. So if we talk about mycosis fungoides, this is a disease that can involve blood, that can involve lymph nodes, that can involve viscera. So again, we have to think of all these other compartments to properly assess the patient and properly stage the patient. These patients, again, they can present with various symptoms, but I would say the most classical one is usually patch-like erythematous, so reddish rash, and usually that's in the parts of a patient's body that are not exposed to sunlight, right? So that's interesting, and that's a little bit more typical for CTCL. And patients may have pruritus, so itching at the lesion site as well. And these lesions can stay stable, so they can stay in the same location, or they can be growing and expanding. So if the clinician is treating the patient, and the usual sequence is first, this patients are thought to have fungus, so they're given an antifungal cream. Then they're thought to have an allergy, and they may be given a steroid cream, but they're not improving. It's best to have the rash biopsied to rule out mycosis fungoides. But of course, there are many other presentations, because again, this is a highly heterogeneous disease, and the skin lesions can be presenting as patches, so flat, or as plaques, which are raised, or even tumors that have pretty significant thickness. Patients may or may not have lymphadenopathy. Patients may or may not have abnormality in blood counts. Sometimes in some patients, all you would see is hypopigmentation, so lack of color, or hyperpigmentation, so increase in pigmentation, because they are hypopigmented and hyperpigmented variants of this disease. Again, if these are patients who are persistently symptomatic and not responding to the regular kind of garden variety rash treatment sequence, it's best to biopsy the lesions and have an expert review to rule out CTCL. One of the most important steps is for the healthcare provider to think, am I comfortable talking about this disease? I'm not even going to say treating, I would say talking about this disease first and explaining to the patient disease course, treatment course, then asking yourself, am I comfortable treating this? And third, am I comfortable committing to this patient? So CTCL is technically skin cancer, so it's a skin lymphoma. But at its lower stage, patients can have extended survival and normal lifespan. But when the word cancer is heard, patients can be very scared. And so it's important to have an experienced healthcare provider who understands the course of this disease and can advise the patient appropriately on what to expect. Additionally, staging needs to be performed, and the staging depends on the type and extent of skin lesions. Also, the provider needs to know how to stage the blood and be able to run and interpret blood flow cytometry to determine whether there is blood involvement. And in addition, I would like to collect the signature of these abnormal cancer cells in the blood to see whether there is a molecular signature present, which is also important for staging. Additionally, routinely in other lymphomas, we do CT scans or PET scans to determine the staging in the lymph nodes and viscera, but actually those studies are not always necessary in cutaneous lymphoma. So again, the provider needs to be comfortable with understanding the disease to know whether initial imaging and then subsequently sequential imaging is even necessary, because unnecessary imaging can generate false positive results, can generate a lot of anxiety in the patient and kind of create this cancer stigma and living with cancer burden on these patients, while really patients with stage 1A disease, which is disease involving less than 10% of the body in the patch stage, has excellent prognosis. And it's really a pleasure to explain to these patients how well they can do and bring them relief, because a lot of times they're anxious and scared. So CTCL patients need multidisciplinary care in many cases. And the reason why is because, yes, some of them will require only topical treatments. And some dermatologists are comfortable and very comfortable managing topical treatments and managing light therapy, while other dermatologists are not comfortable doing so or do not have time for enough follow-up. So I would say in lower stages of disease, where there is only cutaneous or only skin involvement, dermatologists may take a lead, but not always, because there's always not always a dermatology provider who is comfortable with this disease. And in many cases, the malignant hematology expert with an interest in CTCL can take a lead in this disease. Best follow these patients, especially the ones with cutaneous involvement and active cutaneous involvement, follow these patients in parallel with dermatologists. Additionally, these patients may benefit, and some of them benefit from radiation therapy. So again, prompt and appropriate referrals to radiation therapists are very important. Additionally, patients with CTCL at various stages may be profoundly immunocompromised, especially patients with Sézary syndrome. So it's important to have an infectious disease specialist communicating with the lead hematologist who is aware of these patients' baseline immune function, who is aware of the specific infection risks that they have, and who is available for referral if necessary. Additionally, these patients may experience emotional problems, as this is a lifelong incurable disease, and it is useful in many cases to have a psychologist or a psychiatrist who can participate in care and help these patients with emotional relief from their disease burden. Uh, Really, what it comes down to is establishing good relationships with dermatologists at your institution. If the lead provider functions in a large cancer center or the hospital system, or with the local dermatologist, because again, in ideal world, it would be fantastic to have a one dedicated dermatologist with whom a malignant hematology specialist is partnering for the care of these patients. But unfortunately, we do not live in an ideal world. And what happens is that many times patients' insurance would work with one provider but not the other provider in dermatology. So that's why it's important to have connections with several and really have a good communication. So in my clinic, for example, we have just we're basically a text away, a phone call away, an email away. Make sure that we keep track of patients' cutaneous findings via official photos that we document in the chart, that we can exchange with the dermatology providers. And so that way, malignant hematology provider can tag team with the dermatologist to co-treat these patients. Sometimes what happens is that patients come to me and they tell me, oh, dermatologist didn't do anything. They just gave me cream after cream. So basically, they don't understand that really their particular case, topical therapy is the best therapy and the therapy of choice because of the lack of systemic side effects. So I think sometimes dermatologists actually need support of malignant hematology physician validating treatments that they are prescribing and supporting treatments that they're prescribing, as well as supporting the adherence. Because again, in early stage disease and sometimes more extensive stages, the mainstay of the treatment is topical. Many patients have problems with compliance just because it may be hard to stick to applying cream to large body surface areas or to areas of their body that are hard to reach. Patients tend to forget to apply creams, or for example, when they travel, their compliance can lapse. So again, I feel like when dermatologists and hematologists work in concert, the patient care is much more consistent and patient compliance definitely goes up. It's very important to understand from the very beginning what kind of impact this disease is having on the patient's life and on patient's function. Understand their emotional attitude towards the disease, because as I have mentioned, some patients are devastated by the diagnosis because they heard the word cancer. And so it's extremely important to help them understand their disease and give them hope and support them in what likely is a full life for many years to come. It's important to empower patients to understand their disease. I have some patients, for example, where I can say, you know better than me how to manage your flares, right? Because they became active participants in their own care. And I explained to them to start with how to use various creams and modalities, but then they picked up there and worked with their disease, and some of them even developed their own little routine on how to control their symptoms. So I think it's extremely important to empower patients as active participants in their own care. And additionally, a lot of CTCL patients benefit from specific type of skincare, such as using moisturizing creams, for example, avoiding detergents or other topical treatments that have any perfumes or dyes, and that can be extremely helpful. And again, it is empowering because patients feel like they can do something that can help them. First of all, I really like that the consensus is patient focused. In all cancers, patient is in focus, but even more so with CTCL, because as I have mentioned, it is a lifelong disease. So for some lymphomas, we follow patients for a limited time period and we can cure them. But with CTCL, we have to follow these patients for the rest of their life in majority of cases, and the disease has relapsing, may progress throughout the years. The consensus is very important. First of all, it calls for access to expert referrals and to resources for these patients. And that, as I have mentioned, is the key, because these patients need a lead physician to help them establish treatment course and to understand their disease. Consensus also calls for providing support to clinicians to establish multidisciplinary clinics to help with this patient's care. And multidisciplinary clinics are really fantastic. We have multidisciplinary clinic where patients are seen by radiation oncologists and dermatologists and lymphoma specialists at the same time. These clinics help patients feel empowered. They see and understand that we work together as a team. These clinics help gain trust and expedite time to diagnosis and appropriate treatment. And really, they help establish trust with patient to the point where potentially even in the future, we need less visits for these patients because they understand the disease course better and they understand that they're in good hands. But unfortunately, these clinics may be hard to organize, especially in the current healthcare environment that is very fast paced. So definitely it would be nice to have support in organizing such clinics, maybe have experienced sites teach not so experienced sites on how to run such clinics. Additionally, the consensus calls for expanding resources in under-resourced countries, which of course is extremely important. As I have mentioned, these patients need multimodal approach, expert pathology, and also they need access to very expensive medical therapies in some cases. Providing access to care in under-resourced countries is essential to help these patients. The consensus also calls for developing new technologies. That is important because I think that despite the fact that medicine is moving forward very fast, we are still in kind of archaic times in terms of medical records because our medical records are not shared between different institutions. We still have to request them as paper records. Sometimes it's hard to obtain pathology slides and review. So again, having technology, for example, that would help us have universal access to medical records would be tremendous. Having technology that would help us have access to patients' pathology slides, having technologies that maybe would help aid in diagnosis of this disease, such as AI technologies that would help with pathology analysis would be incredible. One of the most important points in the consensus is driving awareness of this disease, because I think that really very few clinicians think about CTCL. It doesn't come up very often. It is a rare disease. And when it does happen, when the patient comes with this diagnosis or the biopsy comes back with this diagnosis, I think sometimes the clinicians are very concerned and they themselves are a little bit timid or scared. And then subsequently, patients feel the same way. And so there's basically a lot of fear that can be associated with this diagnosis. So just having a document, having a statement that even educates primary care providers, dermatologists, community oncologists on this disease is extremely valuable. I can actually sense that there is increasing awareness of CTCL diagnosis and the fact that it is best to refer these patients to the centers of expertise. Several incredible organizations that are active in CTCL, such as Cutaneous Lymphoma Foundation, and also International Society for Cutaneous Lymphomas. So just having these sites available is extremely useful. And these sites provide lists of experts in the disease, experts that can be referred to or contacted. Many more referrals now for the specialist care of this disease. I think that in general, these patients can be treated locally, they can be treated in community, but in conjunction with an expert. And a lot of times I share these patients with community providers, greatly improves the care of these patients and has an impact on disease course.